Thanks, Len. So we thought we'd actually start by just giving a little bit of a preview for where we think the next kind of 12 months or so are going to be in terms of the PCSK9 inhibitors in terms of trials. So I'll only update that for about 10 minutes and then hand over to Richard. So we now have a range of monoclonal antibody development programs. And I think this slide's really cool and really important to point out that we only actually discovered the protein in 2003. In fact, it wasn't even called PCSK9. So we haven't even had PCSK9 since 2003 because we called it something else. And it was only then that we really discovered that it was the gain-of-function mutations that are associated with autosomal dominant hypercholesterolemia. And if you kind of think, in that short period of time, you've had all the biology, all the genetics that we really talk about, like we've known it forever, has all happened in that short period of time, and we've developed monoclonal antibodies, and we've had a whole range of phase 1 and phase 2 studies, and we have these drugs approved in a range of countries, and in some countries you can actually prescribe them to patients, heaven forbid. So it really is for the field of cardiovascular medicine, it is rapid progress of science informing a treatment that is brought to clinical practice. The next clinical trial on the PCSK9 story will actually be GLAGOV. Be reported at AHA, and it will be the serial IVUS study. We have randomised 968 patients who have angiographic coronary disease. They've been treated with a stable dose of a statin for at least 4 weeks. They have an LDL that's greater than or equal to 80 or between 60 and 80 milligrams per decilitre, provided they had one of a range of risk factors, kind of combinations there. And we did that because we knew that there were people who had lower LDL cholesterols who still have progressive forms of disease. And so they should be included in the study. And I think that kind of speaks again to the answer to Andrew's question that yes, there are patients who actually have progressive modifiable forms of disease. We just need better clinical tools to identify who they are. Patients will be randomised, have been treated for 78 weeks with monthly injections of evolocumab, 420 milligrams, using the 3 little injections versus placebo. Everybody has completed the study. We report that at AHA, and Amgen have issued a 1-line press release saying the study met its primary and secondary objectives. You can interpret that however you want. Here is what is the really exciting part of this story, which are 4 phase 3 outcome trials that are all ongoing. Fourier will be the first to report out, probably in the early half of 2017, is what everybody's best guess is. 27,500 patients who have had a previous myocardial infarction, stroke, or PAD, so legitimately hard ischemic entry endpoints to get in. Background therapy of 20 milligrams of atorvastatin or equivalent, LDL cholesterol's greater than 1.8. You see the composite kind of primary endpoint there. In that study, patients were treated either 2 weekly or monthly, so that's a little different than GLAGOV. GLAGOV was very much designed to try and reflect a Fourier-type population, so hopefully one can look at the results and feel that they're very similar types of patients. GLAGOV is different in terms of everybody who was treated monthly. Odyssey outcomes, 18,000 patients who have had an acute coronary syndrome between 4 and 52 weeks ago. When the study started, I think it was 4 to 12 weeks, so that was changed during the course of the study, which I think everybody in the field thought was a good thing. Quote, evidence-based medical therapy as background. LDL cholesterol's again greater than 1.8, 2 weekly treatment. You see the endpoints there. And then you see the SPIRE-1 and SPIRE-2 programs with Pfizer. And really those 2 studies purely differ in terms of what the entry LDL cholesterol required is. SPIRE-2 is a higher LDL cohort, and in fact, some sense that there may be a reasonable number of high-risk primary prevention patients with high LDL cholesterols, and so they will all read out within the next couple of years, and I think that's very exciting. There's some early data that certainly gives us hope. These are the two reports in the New England Journal from last year of the pooled longer-term lipid studies from evolocumab and alirocumab showing significantly less cardiovascular events in both programs, early separation of the curves, and hazard ratios of about 0.5. These were pre-specified adjudicated events. So they're meant to do these. The analyses themselves I've never been a huge fan of. I think it's kind of questionable science myself. These are low-risk patients. The event rates on these axes are relatively low. These aren't the randomised prospective outcome trials. They are ongoing, but they give us some hope that there will be benefit. I don't think anybody seriously sits around an ad board and thinks that any of those last 4 trials I showed you are going to show 50% reductions in events. But at least there's, I think, some hope to read into that. This is pooled data that Chris Cannon looked at the alirocumab experience, pooling their longer-term experience and looking at the relationship between achieved LDL cholesterol levels and MACE, and the relationship continues to appear to be direct, down to an LDL of 25 milligrams per decilitre with reasonably tight confidence intervals down here in this low S plot. So that's interesting, and they were reported very similar observations that we've seen in terms of the CTT analysis. So hazard ratio of 0.76 per essentially millimole per litre reduction in LDL cholesterol in a cohort where the LDLs go down to lower than the studies that have typically been included in CTT, suggesting that it will continue to be observed. Safety is going to be really important here, and in general these agents are safe and well tolerated. The two big questions really are, is having a really low LDL cholesterol safe? And I'll show you a little bit of data in relation to that in a minute. The other is this kind of concept of, are there going to be neurocognitive issues? I personally don't think there will, and I think that if you treat these patients long enough, you very well may see neurocognitive benefit. That being said, this is the long-term safety data from OSLA. 27 versus 4, or percentage 0.3 versus 0.9, which was statistically significant. This is not formally evaluated neurocognitive function. This is simply patients coming in for their routine visits in studies, doctor or nurse ticks the box, neurocognitive AE, and so that can be everything from, I couldn't quite remember yesterday where I left my keys, to a whole range of different things. And so what's really important is now that we have a number of these programs thinking through what their strategy is in terms of formal evaluation of neurocognitive function. Ebbinghaus is a sub-study built within Fourier of 2,000 patients where they are undergoing formal evaluation with 3 validated executive tools of executive function. And I suspect the other programs will move forward with that. I've always been a little dubious about that, in light of the fact that if you think about it, these are people in their late 50s, early 60s in general. They're probably relatively low risk for significant cognitive decline in the course of the next 2 to 3 years, which is essentially the treatment duration for almost everybody in the maximally treated patients in these studies. And so I don't necessarily think a negative result in terms of all of that completely reassures me, and I think that we'll need to obviously have really proper post-marketing surveillance and long-term follow-up in these patients. That being said, I think a study like Ebbinghaus can be really informative for me in trying to get my patients to be compliant with these therapies. I mean, I start a statin, patients usually going to start complaining about foggy head and all this kind of stuff relatively early, because either they read the newspaper or somebody else hasn't told them. And so the ability to be able to demonstrate that even over a year and a half that there's no significant decline in executive neurocognitive function, I think would be useful. The LDL cholesterol going to very low levels is clearly an important thing. There's some reassuring data from the statin studies that have been performed to date. Here's Prove It, looking at a range of safety parameters looked in patients stratified according to achieved levels of LDL cholesterol. There doesn't appear to be a signal. Paul Ridker and his colleagues presented very similar findings from Jupiter. I would probably make the point that clinical trials are rarely powered to actually look at any significant difference between any AE when you look at the whole cohort. So when you slice and dice the data like this, it's almost impossible to find a difference. That being said, it's reassuring. I wanted to leave with 2 or 3 final comments. This is a study that I think is very exciting. We have launched a study called Impact LDL, in which we're going to look at the impact of PCSK9 inhibition on lipid levels in Aboriginal adults. It's a study we're doing with Alex Brown. Everybody has established atherosclerotic cardiovascular disease, diabetes with an additional risk factor, or they have a Framingham risk score greater than 15%, and they have an LDL cholesterol greater than 2.6 millimoles per litre on maximum tolerated statin therapy. And so we are doing this, we've just started this study at multiple sites around the country. So anybody who has access to a lot of Aboriginal patients who may be interested in that, please reach out to me. We are certainly looking for partners in that study. I was really keen from the start for us to be able to bring therapies that potentially have the greatest impact to the people who typically need them the most and typically don't have any access to them at all. And then finally, and this kind of talks a little bit into the discussion we've had at the end of David's talk, is there are other ways to skin a cat, and we saw it referred to during Karim's talk this morning in terms of a table showing a whole bunch of different ways of targeting PCSK9. Here is stage number 2, and it is liver-targeted RNA inhibitors. And so this is an approach which is already in human evaluation. There will be a phase 2 clinical trial in 450 patients presented at AHA called Orion. This uses a delivery platform by Alnylam using a GalNAc platform, which appears to be safe and well tolerated in non-human primates. And then in the early human studies, one sees a very good LDL cholesterol lowering, probably in the order of 50%, so maybe a little bit less than the monoclonal antibodies, but still pretty good. But where the advantage may be is the durability. And these approaches are being developed with the idea that this is one injection a quarter. So suddenly you're 4 injections a year, and that turns, particularly for patients where compliance may be an issue, absolutely changes the whole ball game in terms of where the treatment's administered, primary care, all of those types of things may be really important there. Now, while this field is moving very quickly, it can really not ride on the coattails of the monoclonals at all. Because the idea, and I think Leon's absolutely right, the idea of playing around with biologics, particularly when you target them directly within a hepatocyte, safety goes right back to square one. And so this program will have to basically do the whole thing, but it really does kind of give us the hope that maybe we do have a very different biological approach, which may be really important for particular types of patients. And I think there's a lot of excitement. So I'd watch out for AHA, because I think the next instalment of that will be really interesting. On that note, I'll hand over to Richard, and then we'll have a discussion afterwards.
Thanks very much. Well, I'm going to show some cases and just show a little bit of information about PCSK9 inhibition in diabetic patients as well. So these are actually all real patients that I've been managing or mismanaging, and you can deal with that in question time. The first is a 65-year-old woman with familial hypercholesterolemia that was diagnosed in 2009 and actually came to us from Andrew Wilson at St Vincent's. Her Dutch lipid score was above 8. In fact, it was 17, I think, from memory, so it was pretty solid. She had angina and stents in 2009, and in 2013 had a non-ST elevation myocardial infarction. At the time that we saw her, she was on triple therapy with rosuvastatin, ezetimibe and fenofibrate, but despite that had an LDL of 5.9. She's got elevated triglycerides, so whether she's got too much ApoC3 as well, I'm not sure, but she's been pretty consistent with that modest elevation of triglycerides, but without a low HDL. The HDL's always been reasonably high. So we actually commenced LDL apheresis in this lady, and she typically will, you can see the LDL, even in the pre-apheresis, this is 2-weekly apheresis, the LDL pre comes down a bit, so the steady state generally in apheresis results in a lower LDL level than before the apheresis, but it certainly changes quite a bit. So post-treatment, the LDL gets down to around 1.8, and then over 2 weeks drifts up to about 4.4. You can see triglycerides get pulled off as well, and so does the HDL, but and again, they come back by the end of the time. So this was somebody that we thought possibly would be suitable for PCSK9 inhibition. And our hand was forced a little bit because this year she's had a permacath. Most of these people we apherese actually via their cubital veins, but she was a fairly small lady, didn't have very good veins, and so she'd had a permacath. That got infected and had to be removed early this year, and so it was a good opportunity to try her. So she started on evolocumab 140 milligrams every 2 weeks, which is the standard dose. And just recently, in fact, a couple of days ago, I got her lipids back. So she stayed on the triple therapy. She's still on her rosuvastatin, ezetimibe, and fenofibrate, and has had a really quite spectacular response with her LDL dropping to 1.5. So no apheresis now for several months, and a very good LDL level. So she's currently on the special access, or rather the product familiarization program with evolocumab, but probably will qualify for PBS treatment. And certainly she's not going back to LDL apheresis at this stage. So that was really a great result. Another patient, this is actually a close friend of mine, a biochemist, retired biochemist, who set up and then sold a biotech company. He developed type 2 diabetes a few years ago. He's had fairly long-standing hypercholesterolemia, which actually preceded his diabetes, but statin intolerance, and I suspect his statin intolerance is not real. He definitely get aches and pains, and in fact he went so far as to see a neurologist and was muscle biopsied to see if he could find any associations with his myalgias and statin, and nothing showed up on the muscle biopsies. He took himself off for a coronary CT angiogram. He's been asymptomatic, and that did show multiple stenoses of 30 to 50% in several of the vessels. His lipid-lowering therapy has been, he's been able to tolerate 10 milligrams of rosuvastatin, although still tends to get some aches and pains with that. And he's on ezetimibe 10 milligrams and fenofibrate 145. And then for his diabetes, he's currently taking empagliflozin, glycoside, and metformin, and he's also on antihypertensive therapy. So he was a bit concerned about his multiple stenoses and wondered if he could have some PCSK9 inhibition, and he's worth a few bob, so he was quite happy to pay for it. These are the most recent on-treatment lipids. So on his 10 milligrams of rosuvastatin and 10 of ezetimibe, he's got an LDL cholesterol of 2.3. HbA1c is fairly good at the moment. He's at 7.0%. So he has now been taking evolocumab on private prescription for about 3 months, and again has had a spectacular result within his LDL dropping to 0.5. Now, interestingly, and I can't show you this, but he was so pleased with this that he thought he'd stop his Crestor, and in fact he did stop his rosuvastatin. Firstly, it made no difference to his myalgias, which is what I'd always suspected. But secondly, without the rosuvastatin, the LDL was close to 2. So and I said, you better get back on it. And this is actually the repeat back on the combination of the drugs. So certainly a very nice result when he takes all of the medications. And he's now fairly happy to take his Crestor because he's convinced now that it probably isn't responsible for his myalgias. Now, here's a guy with fairly well-controlled diabetes. He's on oral agents. And so given that we've had quite a lot of concern about very low LDL levels, possibly accelerating diabetes, he certainly asked me about that. And there is some quite a bit of data now on diabetes and PCSK9 inhibitors. So this is the alirocumab study. There was a study called Odyssey, which is one of the long-term trials, which was 150 milligrams every 2 weeks versus placebo. And there were a fairly reasonable number of diabetic patients in that study. The left two columns are the people with diabetes and the people without diabetes, and you can see LDL levels very similar. Triglycerides obviously a little higher in the people with diabetes. Here's the Lp(a) median. So interestingly, the diabetic group tended to have a lower Lp(a), and ApoBs of around 100. In terms of response to alirocumab, it's absolutely identical. So you can see the lipids with and without diabetes on alirocumab both getting an absolutely equivalent reduction in LDL. And HDL levels, small rises, which is what we've seen in most of these studies. Some reduction in triglycerides, sort of 18 and 16%, and the expected reductions in Lp(a), 27%, 25%. So certainly, in terms of really all of the lipid parameters, in this particular study, the diabetic patients did just the same as the non-diabetic patients. Now, this has also been looked at with evolocumab, and the way this study was done, there was a number of previous studies, and then patients went in a 2-to-1 randomization to either evolocumab or standard care. So they'd already been on it, and then some of them stopped it and some of them kept going. There was 109 people with type 2 diabetes, and these are the really interesting groups. There was 134 with impaired fasting glucose and 425 with metabolic syndrome, and then 543 who didn't meet any of those criteria. Ages fairly similar. The diabetic patients very slightly older. And obviously BMIs higher in all of the groups with some degree of dysglycemia or metabolic syndrome compared to the others. Statin use higher in the type 2 diabetic patients to start with. And so this is when everybody got the real thing, and then this was the group that went back to standard care. So you can see LDL comes down as expected and goes up. And just like the alirocumab study, there was no difference in the LDL response. So the diabetic patients, those with impaired fasting glucose, and those with metabolic syndrome, all getting around a 50 to 55% reduction in LDL. That was consistent across the 1-year study period. In terms of the individual components, rise in HDL, again, pretty similar in the groups. Reduced triglycerides, again, perhaps not so much in the people with diabetes, but around 7 to 10% in the other patients. And again, pretty consistent reductions in Lp(a). In fact, 40% in the diabetic group and around 30% in the other groups. Now, I think the really interesting data out of this, and I mean, you could argue that it's a year is way too short, But it was pretty reassuring if we look at, this is the, on the left is the fasting blood glucose data, it's in milligrams per deciliter, but that doesn't matter. And here's the HbA1c. So there was absolutely no change in the fasting glucose, particularly in people who would be very prone to developing diabetes, those with impaired fasting glucose, and we can see the HbA1c levels were completely flat in that group, and same in the people with the metabolic syndrome. Now, I'm not aware of whether some patients, the numbers that might have developed diabetes in this short period of time, I imagine it was low because of fairly low numbers, but certainly HbA1c absolutely rock steady and no difference between the two groups, even though some of these people got down to very low LDL levels. So I think we'll obviously have to wait for the larger long-term studies to see the diabetes prevalence, diabetes incidence in these trials, but I think this at least was reassuring enough for my patient to say that he was happy enough to take it. I'll show you another case now. So this is a 39-year-old accountant sent to me by Ian Meredith. He had a family history of his father having coronary bypass surgery at the age of 45. His father's cholesterol was 9.6 before he was treated. His mother had high cholesterol on a statin for many years, no coronary disease and no coronary disease in her family. And I must admit, I assumed that she had polygenic hypercholesterolemia. There was a maternal grandfather that had died at 30 in his sleep, but that's her grandfather. Her parents hadn't had any problems. There was so Mr. JR had a first myocardial infarction and a stent at the age of 36. He had further angina, another stent at the age of 38. And at that stage when I saw him, he was on 80 milligrams a day of atorvastatin. He had bilateral Achilles xanthometer. And remember, this is on 80 milligrams of Lipitor. His total cholesterol was 11.7 and his LDL was 9.9. So I switched him over to rosuvastatin 40 and added ezetimibe, and the LDL came down to 8.0. So I had marked him as a severe, probable severe heterozygote, and in retrospect, it probably wasn't true. He commenced in LDL apheresis in 2004, so that was the pre-levels, so before treatment, LDL around 8. On apheresis, he's coming up before, and again he was getting fortnightly apheresis to about 6.9, dropping down to about 2.4. So certainly not ideal control. We could argue that his average for somebody who's secondary prevention is still much worse than that. Although there is some feeling amongst apheresis people that the levels may be less important than just the amount of LDL that you actually remove, and so this still represents a significant material benefit, even though we're not actually achieving very low levels. So when evolocumab came along, started him on the standard dose, 140 milligrams every 2 weekly, and you can see that compared to the previous levels, we're now getting, instead of a pre of 2.4, post of 2.4, we're getting a post of 1.8 and an LDL of 5.1, but a fairly modest response. And so I'm not quite sure what the explanation is, but certainly an explanation is that he may well be a homozygote or a compound heterozygote with because one would have expected a better response to evolocumab. Now, if he's homozygous FH, theoretically we should be treating him with 420 milligrams every 2 weeks, and so I guess that's a possibility. The other thing is that I just accept that he's now much better off, but keep him on his apheresis, and we can have a discussion about people think might be a good idea. We're in the process of genotyping him. He hadn't previously done it. And the final case is a Mr. JP, who is a 52-year-old draftsman and is managed by Omar Farouk at the Austin. He presented in 2009. He had some chest pain after a hematemesis related to non-steroidal anti-inflammatory use, and an angiogram at the time showed an 80% right coronary stenosis, and he had a bare metal stent inserted, and he was commenced on atorvastatin. Now, he really didn't have a lot in the way of risk factors. He was a non-smoker. There was no family history of coronary disease. Interestingly, no diabetes, and his blood pressure was 117 on 68 on mean on 24-hour monitoring. So Omar looked at him pretty closely to try and work out what was going on. He had an in-stent restenosis in 2010 and a drug-eluting stent inserted. He was changed to rosuvastatin 40 milligrams. At that time, his LDL was 1.0. Despite that LDL level, he had progressive disease and required coronary bypass surgery in 2011. And in 2014, when Omar asked me to have a look at him, he'd just had a new osteal circumflex stenosis and another drug-eluting stent in. So, fairly nasty progressive disease in a relatively young man who's really achieved a very low LDL level. Well, when we did his apoproteins, he had low ApoB, but his Lp(a) was 0.83. And this was his lipid profile. When I saw him, he's certainly got a low HDL level, and given that he's on 40 milligrams of rosuvastatin, but a very good LDL and this high Lp(a). And so I guess the question here is, should we, given that we can achieve at least a 30% reduction at Lp(a) level, start him on a PCSK9 inhibitor? Now that's going to result in an LDL of presumably almost unmeasurably low. And so if we were to do that, would we drop the dose of his statin so that we don't get the LDL down too low? Would we just not worry and have an LDL of 0.5? Or indeed, and will a 30% reduction in this man be enough to stop his progressive disease, if indeed that's what's causing it? So that is the last case. And I guess, Steve, do you want to come up and have questions and discussions about those?